You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. Welcome to Hit Play Not Pause, the podcast that won't give you nausea, random bleeding, or sore breasts, at least not intentionally. All right, seriously, this week's show is brought to you by request from, brought to you by request from quite a few of you in our community who asked that I do a show talking about the potential side effects of hormone therapy. And I just want to say, before we get too far into it here, right at the top, because I know that some people get concerned that when we talk about side effects or risks that we're dissuading people or maybe scaring them away from getting the care they need. This is not 100% not designed to do any of that. I actually think every single woman should have a visit with her doctor when she turns 40 or anytime she's approaching or has gone into menopause to have a very thorough, nuanced discussion about hormone therapy. And I think hormone therapy is an essential tool, and essential not in that everybody needs to be on it, but essential in that it belongs in all of our toolboxes as something that we can consider. So that's where I stand on that. I wanted to say that right up top to make it clear. What I don't love and what this conversation addresses as well is that women aren't given these thorough discussions of hormone therapy. So they leave the office or they pick up their prescription and they start using it. And sometimes they feel better quickly, which is awesome. But sometimes they actually feel worse. Or maybe their hot flashes go away, but now they have bleeding or they have other disconcerting symptoms and they feel just as confused as ever, if not more so. And as I talk about in this episode, I was actually one of those women when I first waded into the hormone therapy waters myself. And as I mentioned at the top, it's been a requested topic. So I thought, what a great opportunity to call up our resident hormone doc, Dr. Carla DiGirolamo, and just have a conversation about what can happen, how long it might last, and what you can do about these potential side effects. And I love Carla because she lives and breathes hormones. As a longtime double board certified reproductive endocrinologist and OB-GYN specializing in infertility and menopausal medicine, and now in her own practice, which you can find at drcarlad.com, she has just seen it all. And she is very plain spoken about it and straight shooting, which I completely love. So I hope you enjoy this one as much as I did. Okay, reminder, our very popular Navigate Menopause course is still now on sale for another day or two here. For the first time, we are offering an on-demand as well as the usual community group coaching version. And in that coaching version, you get to work through your issues during our live Zoom sessions with myself and Linda and our experts, where you can ask your questions and you get to really connect and share your experiences with us and other active women going through the same challenges you're navigating. I have seen some real transformation and magic happen in these courses, so head on into the show notes, check it out, and I hope to see you there. All right, before we get to it, give us a follow on Instagram and Facebook at Feisty Menopause. Come join our ever-growing private Hit Play Not Pause Facebook group, where we have those 34,000 women helping each other out. And if you like the show, please share it with your friends. It helps us to grow. Thanks as always for your kind ratings and reviews. I really appreciate them. Before we get to it, finally, very quick thanks to Peri Sport Underwear for covering our behinds and supporting this show. We love some good tech underwear that wicks away moisture and doesn't chafe, bunch, or otherwise cause discomfort while we're out doing our thing. So thanks, Peri, for your support. Okay, enough of me. Let's have a few words about those awesome sponsors and get on with the show. All right, Carla, welcome back to another one of our special episodes. How are you doing?
I'm doing great. Thanks so much for having me once again.
So today, by request, actually, by audience request, we're going to be talking about side effects of menopausal hormone therapy, which I thought was a really interesting topic to cover because, we talk about risks and benefits, which we'll get into in a bit here just to start the show. But a lot of people in the Hit Play Not Pause group and people coming into my DM sometimes are like, my breasts hurt. This is happening. This is happening. And they're not expecting what are just some known and sometimes common side effects that can happen, especially when people start hormone therapy. So thought this would be a good opportunity to talk about those.
I totally agree. I thought it was a great question when you raised it to me. And when you said it, I thought to myself, well, why haven't we talked that much about side effects? I think we get so hung up in the complications like,
Yeah.
breast cancer and pulmonary embolism that we kind of forget about breast tenderness and stuff like that, but it's really important. So I thought it was a great idea to explore this further.
All right, let's just start with the good news here, set the table. Let's talk briefly about the scientifically established benefits that we know so far. When women experience, we talk about hot flashes, vasomotor symptoms all the time, but there's also other things that brain fog, mood issues, anxiety, sleep disturbances, all of that. What do we know right now as far as like what menopausal hormone therapy is beneficial for women in and beyond this menopause transition?
I mean, I think the tried and true that stands the test of time is hot flashes, of course.
Yeah.
And hot flashes can have secondary implications to sleep, which then, if you have poor sleep, then you have brain fog and things like that. So the disruption due to the hot flashes in and of themselves is one thing, but then there's also the secondary effects, which it can be very helpful for. I was actually reading an interesting article recently about they were doing sleep studies on menopausal women. And somnography, I think, is the name of the technique where they put these little electrodes on you
Yep.
as you sleep. And what they were finding out was that you could have a patient who sleeps through the night, wakes up, feels exhausted. You ask them if they had hot flashes. Well, no, I slept through the night, but the somnogram picks up like 15 events that can disrupt you going into deep sleep or REM sleep or whatever. So I thought that was fascinating, that the hot flashes can still be disrupting sleep and leading to feeling poorly rested, even if you don't consciously perceive them by waking up in the middle of the night. So I thought that was kind of a light bulb for me reading that recently. Um, so I definitely think that's the main thing. We know that it's great at preventing osteoporosis. The positive and favorable effects on bone and bone density are pretty well known and pretty well documented in women who are adequately fueled. I think that is a really important point to make because you can give people estrogen therapy, but if they're not getting their basic nutrients like carbohydrates and protein, it's not going to help your bones.
Mm.
A lot of the data that shows the favorable bone effects, they're not in athletes. So the sedentary people, you assume that they're, not in low energy availability or red S. But I think for our population, that's a really important point to make as well, is that the estrogen is not going to help you unless you're properly fueled. We know that it is great for vaginal dryness and
Hmm.
for some urinary urgency and those symptoms. It's FDA approved for that. And I think the data is very mixed on mood symptom relief. Now, mood can be tied to sleep as well, just like brain fog is. So if you
Yeah.
help sleep, you can help mood by default. And then, of course, joint pain is the one that we both deal with quite a bit. Almost all the patients that I've been seeing lately, everyone's complaining of joint pain. And I definitely think that there is something to it there. Again, studies are mixed, but in a low risk individual, I would say let's try it. If we do this for 3 months and it's a game changer for you, then and you're low risk, why not? If it doesn't help, you can always go off of it. So those are the main things that people, I'm losing my microphone here, that people are using hormone therapy for. I think, the thing that people always ask about is well, weight loss and body recomposition. I think estrogen is not so good at that. It could attenuate some fat loss for a short duration of time, but at the end of the day, it all catches up to you eventually.
You mean
Uh,
fat gain
yeah,
for sure. Yeah.
fat gain or lack of fat loss, I
Well, I
think
just
you
did
get
that
to see a
show. I
lot
don't know
of.
if you caught it with Bill Campbell.
Oh,
Um,
no, I didn't.
yeah, that would be an interesting one for you to check out because he's a fat loss researcher. And it was such a pleasure to talk to him because I followed him for decades. And He's always been very confident in his knowledge and abilities. And he was recently talking about how menopause was such a conundrum. And I thought, hmm. So I had him on the show, and it turns out his wife went through the transition, put on weight. He thought this will be easy. I can help her. And he could not. So yeah,
Shocker.
I know. But
Shocker.
it was so validating. I was like, can you say that
Absolutely.
again? But yeah, but we actually I'm contributing to his newsletter this month talking about it was one study that was published in two different, one was in menopause, one was in another, some of the findings were published in another journal, that it did help. It was a randomized controlled trial. It did help with muscle gain in these women who were resistance training and using estrogen only, but it seemed to attenuate fat loss. Like it didn't help with fat loss, or it hindered fat loss in those same women.
Mhm.
So, like the people on placebo resistance training lost more fat than the people using estrogen, though the people using estrogen put on more muscle than so it was a very interesting analysis that way, and he's just been sort of digging into that. But it just illustrates how complex it is, and the study, because they only wanted to look at estrogen, was a little bit of a false setup because they gave them progesterone after the study was all done. They didn't give them a combined therapy, which most people would get because they just
Right.
wanted to examine the effects of estrogen. But I'm like, okay, that's great. However, these women would have to be taking progesterone too.
Yeah, yeah. And you're obviously more familiar with the study. Were these people who were active and active
No, sedentary.
exercises? Oh,
Nope,
so
that
so
was
there's
another
another
issue I
factor
brought up.
there.
Yeah.
Yeah, is
Yeah.
that, that physiology is different
Yep.
from the lifelong active
Yeah.
athletic woman.
That was my point as
Um,
well. I brought that up. I wrote a opinion piece in his newsletter, and I said, "Yep, we need more on." I'd be interested to see like what that looks like with women who are not novel to
yeah,
exercise.
yeah, yeah, for sure,
But
for sure. It's
but
all good stuff.
the point you brought up about the nocturnal hot flashes, I think deserves a double click underline, though, because I think that's really important for women to recognize on many fronts. Rebecca Thurston's work out of Pittsburgh, Jude, I don't know if you know her. She has presented at the Menopause Society a bunch of times, and she does a lot of work where she puts those sensors on women as they sleep, and they vastly underreport their
Mhm.
nocturnal hot flashes. And those nocturnal hot flashes seem uniquely associated with increased risk of white matter hypertensities in the brain, those lesions in the brain, and cardiovascular disease risk and microvascular, vascular
Mhm.
disease and stuff. So it's important to recognize that if you are, waking up like you said and not feeling refreshed, like it's a good idea to attend to that.
Yeah, for sure. And I also suggest people track their sleep with a Whoop or an Aura ring,
Yeah.
because if you are seeing that your, restorative or your slow wave sleep is, 30 minutes when it really should be an hour and a half or 2 hours, you can see the data that tells you that you're spending 90% of your time in light sleep because you just can't get to deep sleep. It's just another piece of data that can be very helpful for someone like me as your physician to try to troubleshoot. So yeah, it's definitely something to be aware of.
All right. So that probably covers most of our general benefits. I mean, this show is not all about that, so we don't want to. I have plenty of shows about that. So let's go into risks that we know, and then let's talk about those side effects.
Sure. So, one thing that became apparent when we were talking about doing the show and doing the research for it is that there is definitely distinction between risks, and that would
Hmm.
be, what is your risk of a heart attack? What is your risk of a stroke? What is your risk of a blood clot or a pulmonary embolism or breast cancer? And then there are side effects. And these are, okay, what happens in the more immediate term when you take it? Are my boobs going to hurt? Am I going to have, am I going to have irregular bleeding, and what's normal and what's not? And I think we get so wrapped up in the risks because, we're talking about death and dying and, really morbid things. And I think people just kind of forget about having that conversation about side effects. And, it's a disservice to people because sometimes side effects can be scary.
Yeah.
So I thought it was a great idea to devote a whole show to that. So I think in terms of side effects, if what I hear from patients when I see them, and this is consistent with the research that I've done in looking at side effects, is that breakthrough bleeding is probably one of the most common, probably the most common side effect from taking hormone therapy. And you can really have bleeding events if you're changing hormone therapy regimens. Like I'll often get asked, well, I'm on oral estradiol, I want to convert over to the patch. What kind of problems am I going to experience? And I always tell them, even though it's estradiol in both cases, sometimes the change in bioavailability, how well the body absorbs it and processes it, is different between an oral
Mm,
pill and a patch, that if the body sees a change, it could result in some breakthrough bleeding. And so I know sometimes people panic about that because now we're thinking endometrial cancer, do I have cancer? And really, we can see that particular side effect for 3 to 6 months.
okay.
Now, obviously, it's a big picture consideration of when you work that up further. For me, I tend to be a little more conservative. About the 3 month mark is when I would say, maybe we should get an ultrasound. And it's important to stay on top of it because you don't want to miss, that hyperplasia, which is like a
Mhm.
precancerous condition. Because the great thing about uterine cancer is that it usually can be caught early and taken care of very effectively. So you don't want to miss it. So it's a balance, of what is a normal side effect versus something that you have to work up. And for me, my threshold between that 3 and 6 month mark is when I would pursue that further. So that's probably the most common one that's out there. Another one that I commonly hear about and that is listed is breast tenderness, especially
Mm,
with progesterone. I find that progestins can cause breast tenderness a little bit more so than the estradiol, but that's my empiric experience. But if you look in the literature, it says that both can
yep.
cause breast tenderness. So that's something to always be aware of too. And these side effects, well, at least a breast tenderness, they say that can resolve in, 2 to 4 weeks, maybe a little bit longer. Because the other common question I get is, well, how long do I give this,
Yeah.
before we have to change? And in the literature, they say 3 to 6 months. But if someone is experiencing something really disruptive, I'm not making her wait 3 months, you know?
Yeah.
So we kind of have to figure out, how disruptive is this, or is this more we're worried that this isn't normal and we need to work it up? If it's not disruptive and I can reassure her that this is normal, and she's like, well, okay, I can deal with a little irregular bleeding, it's no big deal, I'd give it more time. But if she's telling me that she's nauseous, that's another one that can be commonly seen with these. I'm not going to make her wake up nauseous for 3 months. Sometimes you do have to just, bite the bullet and make a change. So those are probably the top three that has been consistent that I hear about from patients and what I've seen in the literature. So that's probably
When
where
I
I would start.
Yeah, when I go to, it's funny, when I went to the NHS, which is the National Health Service, I picked the UK website because they're very complete.
Yeah.
They list for both estrogen and progesterone like a lot of things: headaches, breast pain, bleeding, as you mentioned, nauseous, mood changes, including low mood, depression, leg cramps, mild rash or itching, diarrhea, hair loss. Like a lot of these things, acne, seem like that they're also symptoms that you would expect with the menopause transition, right? Like
Yeah. It's all
it
over the
would,
map. It's all over the map, just like the symptoms. And it makes sense that the side effects are all over the map, because when you think about why we are so symptomatic in perimenopause, it's
mm,
because most of our tissues, if not all of them, are estrogen responsive. There are estrogen receptors, which are the little antennae that pick up the hormone signal and then transmit that signal to the inside of the cell. Nearly all of our tissues have estrogen receptors, so they're waiting for an estrogen message. When perimenopause happens and those messages are erratic, we get mood symptoms, we get joint pain, we get muscle loss, we get bone loss, we get a whole slew of gastrointestinal symptoms, because those receptors are everywhere. So goes it if we are giving someone a hormone therapy, and it's a change from what they were doing before. Those estrogen receptors all over the body are receiving now a new signal. And so that's why the side effects are also so broad, is because so many tissues are estrogen responsive and therefore may respond to that change in medication, whether it's initiating a new medication or it's moving from one medication to another.
And your point about delivery methods is one that I take personally because when I started and we worked together, when I started the fem ring, I was like I had headaches, and I can count the number of headaches I've had in my life on one hand. I had headaches, I was nauseous, I was kind of woozy. I'm like, I do not like this.
Yeah,
And I know there's an adjustment, but I am not willing to feel this way
right.
when I wasn't pursuing it for any like, dramatic reasons. But then switching to the gel, I had none of that.
Yeah, it's amazing when you look up online the side effect profile between transdermal estradiol and oral estradiol. It's different, but it's also different between transdermal preparations, the gel versus the patch. And I was very surprised to see that because it's both, like if we talk about Divigel versus the estradiol patch, they're both bioidentical estradiol. So the compound is the same, the active ingredient is the same, the delivery method is different. So you figure, well, with a patch, I hear a lot about skin reactions and
Yeah.
allergic reactions, like dermatitis. In the gel, you don't get much of that, but and you don't get as many side effects with the gel as you do with the patch. Now, granted, it's one small source that I was looking at, not sure who the people were and what the demographic was of
Hmm.
the population that they surveyed to come up with this data. But I found it to be interesting that the gel tended to have fewer side effects than the patch when this particular population was asked. I found it curious.
And this was the ring, I had the vaginal
That
ring
was
that
the
was
vaginal
and
one.
yeah, and I felt like I was maybe uniquely sensitive to that.
Yeah, and that's estradiol too.
Yeah.
All of these preparations have the same active ingredient, and it is very interesting how the delivery method impacts the side effect profile.
I hear online from people in my community that some people seem, particularly mood-wise, to be particularly sensitive to progesterone. Can we speak to that a bit?
Yeah, I mean, my experience with this just in my entire career in reproductive medicine, we deal with progestins all the time, first in birth control pills. And in birth control pills, and this is relevant for perimenopausal women because they often do take birth control pills, the type of progestin is there's like 4 generations of progestins in birth control pills. And some of the later generations actually have a higher risk profile for blood clots. So we tend to stay away from those a little bit more. But some of the older ones, the third generation and the lower ones, like levonorgestrel and norethindrone, tend to have lower risk profiles. But the side effect profiles, like what is a very troublesome, disruptive side effect that one might experience on levonorgestrel, they may not experience that with norethindrone. And so if we remember, when we're younger, we go to our OB, we're feeling this, that, the other thing, they change the birth control, and it's always the progestin that they change. And it winds up being a little trial and error. So the progestin really, really impacts it. And then, the same holds true for menopausal hormone therapy. We're using all micronized progesterone now because it's more favorable from a risk standpoint than some of the synthetic progestins that are out there. Um, but still, you still get the mood symptoms and the bloating, I find, with even micronized progesterone. So sometimes we have to lower the dose. If someone's on 200 at night, then we can go down to 100. 100 is about as low as you want to go if you have a uterus, because lower than that has not been shown in studies to be protective against that overgrowth of the lining and the precancerous conditions you get with unopposed estrogen. But yeah, the progestin, whether it's a natural progesterone or a synthetic one, that's where a lot of side effects reside.
Does an IUD, a progestin IUD, fix that if people are having symptoms
That's a
there?
That's a great point to bring up. I think in some people it does, but in other people who are really super sensitive, and we should talk about that too. I've had
Okay.
people have Mirena IUDs put in, and they come to me and they say, "Oh my God, I feel like I'm not myself. I
Wow.
woke up as another person." People can be very sensitive to progestins, and the Mirena is the highest dose levonorgestrel IUD. There are three other ones. The Liletta is the same dose as the Mirena, but it's a little smaller. The Kylena and I forget what the other one is. There's another one. There's another one. They're lower doses, which you can play with the dose with the IUD. So I think the higher dose ones are the ones that are more likely to have systemic side effects when you first put them in. They should
Hmm.
abate after 6 months or so, but when people tell me that they don't feel like themselves, you just have get that thing taken out. You can't make someone endure that for 6 months. But there are lower dose ones for people who tend to have those side effects. But yeah, people's sensitivity to their hormones is also incredibly different. So if you think about, you're growing up and say you have a best friend or your sister and you're, having your periods, and one person could have the worst PMS. They're in bed, they're throwing up, they're miserable, and another person doesn't even know their period's coming and it's no big deal. Their
Yep.
hormones are all doing the same thing, all doing the same. If you check their levels, people love to check levels. If you check their levels, everyone's the same. But they have vastly different experiences because their sensitivity, maybe it's the receptors in their brain that are a little more sensitive. That's why they have mood swings or elsewhere. Maybe their uterine receptors are a little bit more sensitive, which is why they have horrific cramps. It's very different. And what's interesting, and this was not a study done, this is just my observation over 18 years as a fertility specialist, people who have terrible PMS are also going to react a little more dramatically to fertility drugs because, again,
Mm.
it's the changing hormones. And I really truly believe it's an inherent sensitivity that each woman has that's different to those hormones. So, that's kind of something that plays into side effects as well, is just how sensitive is any one woman's receptors to the medication.
And that's where, which we've done a whole show on, and we don't need to rehash, but it does dovetail into the conversation that we had about shooting for some magical level that
Right.
it doesn't make sense when you're considering how unique we are to our native hormones, let alone what we're taking.
Yeah, I mean, both side effects and risks are typically dose dependent, meaning the higher the dose of the medication, the more likely you'll have the side effect or the risk. It's well documented that blood clot risk correlates with estradiol exposure. We know breast cancer risk also correlates with estradiol exposure. So, the goal is to minimize the exposure to a point where your symptoms are effectively being treated. And that's the number one thing, is that your symptoms have to effectively be treated. But if you can effectively treat them on a 0.05 patch, and maybe your levels are 30, well, who cares? Why do we have to bring your levels up to
Mine are 15
150?
and I feel great.
Right, exactly. Because if you feel great, that's really the end. That's the end game.
Yeah.
And if you take more medicine than is needed to relieve your symptoms, then you're just putting yourself at higher risk for side effects and risks.
Yeah. And it doesn't, let me ask the question. What bearing does the formulation, whether it be bioidentical, which I honestly think everybody should just adopt that term now because it's out there. I know it started as marketing, but let's just say bioidentical or, not bioidentical hormones have on any of this.
It's hard to say. I actually read something. It might have been in that Lancet article that you sent to me. That was really, really good, by the way. That talked about conjugated equine estrogens. These
Mm-hmm.
are the horse urine derived purified estrogens that they used way back when. That's like Premarin,
Yep.
Prempro, back in the Women's Health Initiative study days. And there was a comment about them having fewer side effects than the pure estradiol, which is, I mean, honestly, they're both bioidentical because they're both biologically created
Right.
substances. So, I mean, the conjugated equine estrogens are also bioidentical, if we're going to use the term. But there was actually suggestion that those had lower side effects because you had different types of estrogens, E1, E2, E3 in there because it's derived from horse urine, impacting the receptors differently. That might have a lower side effect profile than, just pure estradiol. And I thought that was fascinating. I don't know if it's been validated anywhere. I don't know if the results have been corroborated anywhere, but it was an interesting point to think about. I don't know how relevant it is. Nobody uses conjugated equine estrogens much anymore. Although I'll stumble upon someone once in a while who's taking it. If it works, great. Why not? But they're not used as liberally anymore as they used to be, because I think the estradiol patches and the delivery methods have shown to be safer than a lot of these oral methods.
Yeah, as far as
As far as
VTEs, blood
Yeah, as
clots.
far as
Yeah.
that, yeah, as far as that goes, exactly.
Because it's interesting, when we go to the Menopause Society meetings and they talk about Duovy, which does still use conjugated estrogen, right? A
Mhm.
conjugated equine estrogen. There is a notion that there is some benefits to that we might not see with the transdermal estradiol. Susan Davis talked about it on my show too. She's like, we see a lot of with that alone, the Women's Health Initiative saw like benefits for heart disease and all of these things that might be stronger because it's just so many estrogens than what we see with just estradiol, E2.
Yeah. Yeah, no, I think it's an absolutely fair question to ask. And I think this is probably where some of my colleagues in the functional medicine world are coming from, because like I'll have people come to me with compounded estrone plus estradiol. They'll actually be compounding different types of estrogen.
Mm.
And so I can see the logic in that. Whether or not it's any more effective or borne out in the studies, that still remains to be seen. But when you think about biological plausibility in our bodies, when our ovaries are or were producing estrogen, and they're still producing estrogen at a lower level, even post-menopause, that it's not just estradiol. It is estrone. It is all of these others too. And, the receptors will have different affinities and responses to those various estrogen compounds. So I think it's a great question. I'm not sure how we pursue it, but it's definitely a valid point.
That's very interesting. And I bet there is something there that we'll see. I'll bet as we go forward. Because as I've said many times on the show, right now, estradiol is queen of the show. It's just like one, and it's never just one. Like
Right.
if I've learned anything from 30 years of medical journalism, it's never just one thing, ever,
For sure.
ever.
And something as complex as the endocrine cascade, I mean, and especially when you've got every tissue that's got different enzymes that metabolizes that estrogen and its precursors differently. Yeah, yeah, just one is not applicable here.
Yeah, never. So let's talk a little bit about something that our audience will 100% be interested in is HRV. It has come up a couple times. Heart rate variability has come up a couple times in the group that somebody will say, okay, I just started hormone therapy and I don't know if this is a coincidence, but my HRV has tanked. What is going on? And I experienced that a bit when I did that was one of the things that happened with the fem ring. I was like, because I've been tracking for 4 years. And that just that little time I would wake up and I'd be like, what is happening? Because my HRV is usually quite high. It's 90 to 100. And it was consistently lower. And I thought, this is very strange. And it just seemed to correlate with me using the fem ring at that time. And it has not been disrupted by the estrogel that I'm using, the 0.25 gel.
Yeah, and you're also taking the micronized progesterone,
Yes,
right?
yes,
So it's
yes, yes.
interesting. Yeah, I mean, you had a different estrogen progesterone formulation in the fem ring that
Yep,
tanked your HRV, and I assume when you went off of it, it came back up again.
yep, yep.
Yeah. So I definitely think it's real. I just had a patient last week who I saw a couple weeks ago in my new practice that just opened up. Um, she said, Dr. Carla, we started the estradiol, and this was the patch. You know, that's
Hmm.
usually my go-to. I started, and I've noticed my HRV is in the toilet. Why is that? Is this a problem? Is this something that's related to the hormones? And she had a few other questions. So I said, let's schedule a follow-up visit because I want to explore that further. You know, did something else happen? I don't want to just assume that it was
Right.
due to the estradiol. But, you know, you and I started talking about it, and then, you know, she mentioned it. And so I dug into the literature a little bit, and it does seem to be documented even with menopausal hormone therapy as compared to birth control pills, that it can impact HRV. Now, we have a lot of information, more information on birth control pills in the younger population than we do for menopausal HT and HRV. But there is some suggestion in the literature, although controversial, that athletic performance is not as robust when you're on birth control pills for contraception, not for when you're on birth control pills for really hard, horrible, painful periods, which impact your performance, but as contraception, that there are some dips in some of the performance metrics. And you know, the data is mixed, of course, it's not straightforward, but the suggestions out there by many different groups. But the thought in reproductive age is that, well, you're suppressing ovulation. You know, during our reproductive years, we're ovulating. And what the birth control pill does is it suppresses ovulation, you know, as one of its mechanisms. So, well, maybe that is what causes a problem. Maybe the menstrual cycle doesn't like to be, you know, suppressed, and maybe that's the reason. But when we get into menopausal hormone therapy, there's no more cycles. There's no more cycles to suppress because they're gone. So, what's the mechanism there? And again, there's not a lot of literature, but the little bit of digging I did, some people seem to think it's the progesterone that's the culprit.
Hmm.
And I have to do some more digging into the literature to see exactly what I believe, but just knowing, you know, having the experiences I've had with progesterone through the years and how crappy it makes a lot of people feel, it's, you know, doesn't surprise me if it's the culprit in that as well. So so I don't know. I think it's real. I do think it's real. But does it resolve? I think my first question would be,
Mm.
is this something that will settle out like other side effects, you know, to give it 2 to 4 weeks and,
Right.
you know, maybe it'll normalize. I don't
I
know.
didn't give it a month. I wasn't
Well, yeah,
I
it
was
sounds like
feeling
you're
so
felt,
woozy and everything else. I
yeah,
was like,
right.
yeah.
Yeah, because you were feeling like crap.
Yeah.
But you know, for when my patient comes in to see me to talk about this, you know, the things I'm going to ask her, well, how do you feel? Does, you know, we might see the number on the Whoop or the Aura, but
Totally.
maybe you still feel, you know, maybe you still feel great and you can still perform. And, you know, and in that
Totally.
case, well, maybe it'll just settle out. But if she's telling me that she feels like ass, then it's like, oh, well, you know, maybe we need to do something sooner rather than later. But yeah, I think it's the real deal and I think it's worth digging into, but I don't think that there is a ton out there specifically in menopausal women who are no longer cycling and menopausal dosed hormone therapy as compared to OCPs or contraceptive pills in reproductive age women.
Yeah. And to be abundantly clear, this is not meant to scare anybody off of anything, and it's not something that comes up all the time in the group,
Yeah.
but it is something that has come up enough and that I experienced myself that I thought it merited further discussion and digging that we can talk about, ongoing as we do these
Right.
series.
Yeah, for sure, for sure. I think there's lots to be learned out there with it, and I look forward to digging into it a little more. So hopefully a blog will be coming everybody's way in athletic aging. Um,
Yep.
just got to figure it out and look into it.
So let's wrap up. Testosterone is not a part of the traditional menopausal hormone therapy concoction, but a lot of women are experimenting with it or are using it. What are, we do talk about, I guess how do we talk about the risk side effect thing here? Because when you talk about stuff like your voice changing and all of that, is that a risk or a side effect? I guess it's a side effect.
Yeah, I would probably call it a side effect, but it's a severe side effect
Okay,
because
that's fair.
it's irreversible,
Right.
When your
That's why
voice
I was like,
changes, you
where do
don't
we
get
put
that back.
that?
Right.
Yeah.
Just like clitoromegaly, I don't is probably a severe side effect, because that's also irreversible and very disturbing.
Yeah.
Um, but rare, extremely rare. I've only seen maybe one or two cases of that.
Yeah.
And it's usually in women who were thoroughly overdosed in their testosterone. I think hair loss
Mm.
in some places and hair growth in others is what I've seen most commonly in women on testosterone. I think most women tolerate physiologic doses, that is, doses that keep them within the normal range for a female. In the
Yep.
United States, the assays, nanograms per deciliter, somewhere between 20 and 80 are the